This podcast is for general informational, educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients. Welcome, everybody, to another episode of PHM from Pittsburgh. I am still your host, Dr. Tony Tarchichi. For those of you new here, welcome. And for those of you who are regulars, welcome back. Just to remind everybody, I'm a Med-Peds trained pediatric hospitalist here at UPMC Children's Hospital of Pittsburgh in the Paul C. Gaffney Division of Pediatric Hospital Medicine. And we have been coming to you since October of 2016, reviewing different parts of the content specifications for pediatric hospital medicine and interesting topics that have arisen since then. This is a really great episode on a topic, I have to be honest with you, I didn't know anywhere near as much about as I do now. And this is such a big topic, we needed two expert guests, which if you're regulars on the show, you know that rarely ever happens. So let's hit the ground running. Remember, there's free CME courtesy of the University of Pittsburgh. So thank you, University of Pittsburgh. I will introduce my guests in random order, and then we'll welcome them and we'll get started. So our first guest is Dr. Scott Maurer. Dr. Maurer is a professor of pediatrics, chief of the Division of Palliative Medicine and Supportive Care, a member of the Pediatric Hematology Oncology Division at the University of Pittsburgh School of Medicine, and right here at UPMC Children's Hospital of Pittsburgh. Dr. Maurer is the medical director of the large palliative care consultative service focusing on advanced care planning, decision-making support, pain and symptom management, care coordination, end-of-life care, and bereavement care for pediatric patients with life-limiting illness. He studies patient-reported outcomes and psychosocial interventions in children with cancer, and he both teaches and designs curricula for advanced communication skills in the Vital Talk organization. Dr. Maurer received his medical degree from Oregon Health and Science University in 2004, completed pediatric residency at the University of Washington, and a fellowship in pediatric hematology oncology with palliative care training at St. Jude Children's Research Hospital. He's board certified in pediatrics, pediatric hematology oncology, and hospice and palliative care medicine. So, Scott, thank you for joining us.
Thanks for having me here. I really appreciate it.
And our second guest, Dr. Hitoshi Koshiya, who's a PGY5 child neurology fellow right here at UPMC Children's Hospital of Pittsburgh. He'll be completing his child neurology portion of his training this year and will be starting his epilepsy fellowship in July 2024. He's interested in becoming an academic pediatric epileptologist who manages seizures and PSH, which is Paroxysmal Sympathetic Hyperactivity, which if you're saying you don't know what that is, you're in the right place, in children with medical complexities and severe neurologic impairment. He won an early career poster award at the American Academy of Hospice and Palliative Care Medicine in 2024 annual assembly, as well as a junior investigator travel award at the International Neuropalliative Care Society's 2024 Research Summit for his work in PSH, which is why he's with us now. Toshi, thank you for joining us.
Thank you for having me. I'm very excited.
Well, gentlemen, we have to do our disclosures because this is a CME podcast. I will go first, and I'll kick it out to you, Scott, and then you, Toshi. So I was on for the Sanofi Corporation and Advisory Board for increasing vaccination rate in immunocompromised patients, which should have nothing to do with what we're talking about today. Scott, you're up.
I someday want something to disclose, but I have nothing to disclose.
Okay, thank you. Toshi?
And I similarly do not have anything to disclose.
Thank you. So we're going to start very basic here. I didn't know the term was PSH. So in where I trained and where I've worked, I have called it up until a couple weeks ago when I started preparing for this episode, autonomic instability. And before we have three papers we're going to dissect out. For those of you who are regulars in the podcast, this is an old-fashioned paper dissection. We haven't done one of these in a while. We got like three papers we're going to really go talk about. But Toshi D, can you talk to us a little about the history of this condition and the name changes and how come I was so much in the dark here?
Definitely. And I think we're all in agreement in terms of all the name changes, especially because over this past century or so, it's been going through 20 or 30 different names. And I think that's also why it's been so hard to track the literature for some of this. It was back nearly 100 years ago when Dr. Penfield first described it as diencephalic autonomic seizures, where the diencephalon includes the thalamus, the hypothalamus, pineal body, and posterior commissure. And at that time, they really hypothesized it to be epileptiform, epileptic seizures that were coming from the thalamus as a response to increased intracranial pressure. But since then, as we briefly talked about, it's gone through many iterations. It was named thalamic seizures, autonomic seizures, up until they realized it's not epileptic in origin. And then they began to call it everything from sympathetic storming, hypothalamic storming, autonomic storming. And then in more recent decades, they've been trying to consolidate the terminology. They started to call it paroxysmal autonomic instability with or without dystonia, called PAID. And one of the more recent papers that we'll kind of go over today was one of the seminal papers that tried to change the terminology to paroxysmal sympathetic hyperactivity, noting that most of the TBI population, the autonomic instability that they experienced was typically sympathetic hyperactivity.
That's perfect. Thank you, Toshi. Now, the first paper we're going to talk about, for those of you keeping track, there's a seminal paper in this area. It's called Paroxysmal Sympathetic Hyperactivity After Acquired Brain Injury, Consensus on Conceptual Definition, Nomenclature, and Diagnostic Criteria. This was published in the Journal of Neurotrauma on September 1st, 2014, issue 31. So we haven't done this in a while, but what we're going to do is I'm going to summarize this paper, a couple pages on this one, and I'm going to ask our guests to comment in specific areas, and then we'll discuss it, and then we'll move on to the next paper. And I'm putting the papers in chronologic order, so as we progress, we're progressively getting closer and closer to our time period. So we're starting from a decade ago. Now, this paper starts out, and I didn't know this either, talking about PSH, or paroxysmal sympathetic hyperactivity. From here on in, we're going to call it PSH. Has been recognized as a result of acquired brain injury since 1954. But more literature was published in the years 2004 to 2008 than in all the previous years combined. This is mostly an adult paper, but they talk about 8 to 10% of survivors of severe acute brain injury get PSH, and that increases healthcare costs. There's longer hospitalization and poorer outcomes. As of the time this paper was written in 2014, there were 9 distinct published sets of diagnostic criteria for it. So it was just really everywhere. And this article was an international consensus that had 4 aims: develop a conceptual definition, resolve confusion regarding nomenclature, produce a consensus set of diagnostic criteria, and then develop a diagnostic tool utilizing the agreed diagnostic criteria to create uniformity in research and in clinical applications. So everyone's on the same page. This was a 26-member working group that they formed by invitation only, based on clinical or research experience with the condition, clinical discipline, and geographic location. They had numerous subspecialties were involved from Australia, Europe, and the USA. They used the Delphi method to develop the guidelines. We've talked about that before on the show. And they did multiple rounds of surveys, for those who need a reminder, on the Delphi method. And it was mostly done over email. Now, the definition that they used for this was a syndrome recognized in a subgroup of survivors of severe acquired brain injury of simultaneous paroxysmal transient increases in sympathetic, so increase in heart rate, blood pressure, respiratory rate, temperature, sweating, and motor posturing activity. The review supported the use of the term paroxysmal sympathetic hyperactivity. They liked it because it was specific. It was not preempting an underlying pathophysiology, and it accurately portrayed the conceptual definition. So after their Delphi method, they came up with a consensus for clinical items in determining the diagnosis of PSH. There are 10 of them. I'm going to read them, and one I'm going to ask for help on right off the bat. Simultaneity, which I don't love that word, of clinical features. Clinical features are paroxysmal in nature, sympathetic overreactivity to normally non-painful stimuli. The number 4 is what I'm going to ask for help on. Absence of intraparoxysmal parasympathetic features during episodes. I think, Toshi, you're my person for this. What does that mean?
So what it means is during the actual PSH episode, there's no compensatory parasympathetic response going on from the patient.
Okay. Thank you. Now, the fifth feature is the features persist for more than or equal to 3 consecutive days. The features persist for more than or equal to 2 weeks post-injury. And the features persist despite treatment of alternative differential diagnoses. Medication administered to decrease sympathetic features, meaning the patient has to have medication administered to decrease sympathetic features. Lack of alternative explanations. Antecedent acquired brain injury. Those were the 10 consensus for the clinical items in determining a diagnosis of PSH. At the time of this paper, PSH was a diagnosis of exclusion. And they talk about that the pathophysiology here is really not well known. So what they created was a diagnostic tool. They felt a diagnostic tool should have 2 components. 1, addressing the probability of the diagnosis, and 2, assessing the severity of the clinical features. So they created the PSH-AM. There's nothing but mnemonics in this episode, so I'm sorry for all of you listening. But that's the PSH assessment measure. So the first is the Diagnostic Likelihood Tool, DLT. That has 11 points from the 11 diagnostic criteria in the previous page. You get a 0 if it's not there and a 1 if it's there. And not having an item doesn't rule out PSH. And then they create the Clinical Feature Scale, assigns a value of the severity of PSH-like features. And they have a whole table on page 15, 18 in the paper talking about it. And for those stat aficionados out there, the Cronbach alpha for this was 0.8, which, as you know, is quite good. That tells you this is repeatable. So I have a couple of questions from this paper. One, do you all in practice use this DLT or the CFS to diagnose or judge the severity of PSH at all anymore?
I can jump in and take that because I take a lot of these consults, and the answer is no. I think that this is really useful in research and in making sure that when we're studying this, that everybody's talking about the same thing. In practice, what we're looking for is evidence of a sympathetic nervous system that's not being properly balanced by the parasympathetic nervous system. And so what does that look like? That looks like a patient who has tachycardia, sweating, flushing, pupil changes, and irritability that sometimes leads to dystonic posturing or dystonic features. And we look at it as occurring in episodes that sometimes have clear triggers and sometimes don't. And then the thing that we take from this tool that I feel is super important is the idea that we don't have another explanation for what this is. This still remains a diagnosis of exclusion. And even when you're convinced that this is what you're dealing with, we do focus on what is triggering it and can we stop whatever's triggering it, because that's the most effective way to treat it.
And I don't want to downplay this paper. Every other paper I read on this referenced this paper as what they use as the standard criteria and definition for PSH. So thank you, Scott, for that. But I don't want to poo-poo this paper, but I appreciate that a lot. So for those of you listening, the other question I had for this was, I see this in all the literature, even in the pediatric paper, they talk a lot about tachycardia, and they almost say bradycardia doesn't happen in PSH. They don't mention it. And I know for our kids, hypothermia and bradycardia, we have seen for kids with what I used to call autonomic instability or PSH. Is that also a common issue you see in the literature when you're reading about this, that for pediatric, because this paper is primarily based around adults who have traumatic brain injury from an accident of some type. And in pediatrics, it's different. A lot of it's congenital, or there's hypoxic ischemic encephalopathy that triggers it. So do you see that as well, to where bradycardia and hypothermia, you'll see it in clinical practice, but it's not really discussed in the literature? Toshi, you want to take that one?
And I totally agree in that this hasn't been addressed by the literature as much to date, but I really think that it is a very heterogeneous population. as you mentioned, most of the current literature is in adult traumatic brain injury. But as you mentioned, in the pediatric population, the scope looks different. Where a lot of our patients, there's a large prevalence of kids with severe neurological impairment, who are technology dependent. And as part of their neurological impairment, they have poor control of their autonomic system. And I wonder if the diagnosis and management of PSH, if over the next decade or so, if we're going to be able to tease it out between this SNI demographic, severe neurological impairment demographic, and the traumatic brain injury demographic.
Now, normally people like to know why or how we come up with these episodes. And what I will tell you for this particular episode, it just struck me one day on service that I am seeing a lot more kids than I ever used to with autonomic instability. I am consulting our palliative care service headed up by Scott a lot to help with these kids because they'll come in with an infection or something, and that'll trigger autonomic instability or storming, as I sometimes will call it, and we'll need medicine to help calm them down, treat whatever's going on, whatever infection it is. And it just struck me that I'm seeing more and more and more. Do we have, I think, Toshi, epidemiology-wise, do we have numbers on, is this increasing in prevalence? Am I just crazy?
So I think increase in prevalence is something that I haven't seen reported in the literature, but I do wonder with the increasing recognition of this entity, especially now that we have a more unified name for the diagnosis, if that could also be playing a role as part of, in addition to these children with hypoxic ischemic encephalopathy and other severe neurological impairments living longer because of the good medical care that we've been giving. From the epidemiology that we do know, in the adult literature, we know that anywhere from around 8 to 30-ish% of admissions into the ICU can have a diagnosis of paroxysmal sympathetic hyperactivity. And from actually at Pittsburgh, Dr. Erica Fink's group in 2012 in developmental medicine and child neurology, they were able to create a database of 249 children that were admitted to the Children's Institute for Rehabilitation for a diagnosis of either TBI, cardiac arrest, stroke, CNS infections, and brain neoplasms. And they found that 10% of TBI patients and 31% of post-cardiac arrest patients met criteria for PSH.
Thank you, Toshi. Scott, did you want to add anything?
Yeah, I think we need only point to Chris Feutner's article looking at the rise in the population of children who are technology dependent and medically complex over the last 20 years. It's rising on a J-shaped curve because of several factors. One, our ICUs are getting better at helping kids with severe neurologic injury, whether that's a traumatic brain injury or an anoxic brain injury, survive longer. And then the increase in the availability of technology such as tracheostomy and home ventilators, the ability for these kids to live outside of the hospital and live longer. We are seeing a rise in this population of children, and all of these children are at risk for having some form of hypothalamic damage. And they live in a state where their hypothalamus is unable to regulate the homeostasis that it normally regulates. And so you're not crazy. You are seeing more of this because you might also notice that the index of complexity of the patients that you are treating is also increasing. And so this is a symptom that tracks really well with patient complexity, and the population of children living with severe neurologic injury is growing, and that's why you're seeing more of this.
Well, that makes sense. Thank you. Now, our second paper, we're moving up in terms of years, getting closer to 2022 or 2024. This one is Traumatic Brain Injury 3, Paroxysmal Sympathetic Hyperactivity, the storm after acute brain injury. This is in Lancet Neurology in 2017, issue 16, pages 721 to 729. Now, this one is really on the pathophysiology a lot. So, Toshi, I'm going to need your help and Scott's help a fair bit with this one. Now, here's what I have a few pages on this. Pathophysiology is not completely understood. That's how they start this paper. Although most researchers do consider it to be a disconnection syndrome with paroxysms driven by the loss of inhibitory control over excitatory autonomic centers. They say definitive, conclusive evidence of the absence of parasympathetic involvement is not available. But the current consensus at the time of this writing is that autonomic hyperactivity in this syndrome concerns only the sympathetic nervous system. Now, they talked about the syndrome, PSH, is likely to be mechanistically heterogeneous. So identifying the dominant pathophysiological processes responsible for the clinical picture you're seeing in that individual patient could allow for precision medicine. Because from what I gathered from that is each patient will have probably slightly different of a brain injury, and then therefore their PSH will show itself in different ways due to different processes. So if you could figure out the patient in front of you, what exactly is their injury, how exactly it's affecting their brain, you can pick drugs, several classes acting on a range of molecular targets, specific for that patient. Did I interpret that wording correctly, Toshi?
I would say so. And I think that people have tried looking on, let's say, neuroanatomical basis for PSH. There's actually a paper in 2015 by Dr. Hinson in the journal Brain Injury, where they took all the MRIs for the kids, for adults diagnosed with PSH, and looked at with diffuse tensor imaging, which is a modality on MRI where you can look at the white matter tracts to see, hey, is there a commonality in the areas of brain injury? They weren't able to find an exact commonality, but they did see that for patients with PSH, you're more likely to have injury in the splenium of the corpus callosum or right posterior limb of the internal capsule. But the reality is, all three of us have seen patients with a variety of extent and location of brain injuries. So I think this is one of the really exciting areas in neurology where over the recent decade or so, there's been increasing literature in what we call lesion network mapping, knowing that it's not necessarily just the location of injury, but what also matters is what are the areas of injury that you have, what networks that they're connected to, what does that involve? Because we know that not all patients with PSH have hypothalamic injury. Not all patients with PSH have thalamic injury. And it's really, like you mentioned, from patient to patient, the MRI can look totally different and their PSH semiology and phenomenology can be different, but there's definitely some extent of commonality between them. And I think being able to figure out which of these brain networks are most responsible for this, I think is going to be helpful for future treatment options.
Now, Scott, from your perspective, you've treated a lot of kids with PSH. Am I right in saying that you will use different medicines for different patients, and some patients require more medicine, some will require less? So there is a heterogeneity in terms of clinically how a patient presents and how you treat them.
Yes, there is. And, a lot of it is, precision medicine here is a real dream. And if I could have a way of knowing which medicine in my arsenal would be best for a particular patient, that would be great. Right now, there's a lot of finesse here in which drug you pick first. And the therapies are really tailored to the patient. And we do a lot of adjustments to those drugs and have to abandon drugs and go to different drugs. And because of a lack of precision, sometimes patients, the symptoms are so distressing that we're just glad we've got them under control. And so some patients end up on multiple drugs when, my hope as a physician would be to reduce polypharmacy. And sometimes that's not possible because it's a lot of trial and error with picking the drugs that you treat.
That's perfect. Thank you both. Now, the paper goes on that talks about, again, between the 15 years of 93 to 2008, 9 sets of diagnostic criteria were published for this syndrome of all, and then they give some numbers of all the cases of PSH. And this paper also talks about adults, just to keep that in mind. 80% followed traumatic brain injury, 10% followed anoxic brain injury, 5% followed stroke, 5% is in association with hydrocephalus, tumors, hypoglycemia, infections, or other unspecified causes. And they talk about TSH, PSH being caused by TBI at a higher rate. And there's a wide range of reported prevalences in the literature in the pediatrics and adult cases. And their overall clinical impression is that PSH is an independent risk factor for poorer neurological outcomes in patients who've had a brain injury. And then they get into the mechanism pathophysiology, and this is where I'm going to get some help. So what they say is there's a diffuse of focal injuries disconnecting one or more cerebral centers from caudal excitatory centers. That's one model, the disconnect model. And the second model, they talk about this excitatory inhibitory ratio model. It's suggesting some like a two-stage process with disconnection of descending inhibitory pathways causing spinal circuit excitation. Paroxysms then resolve in response to recovery of the inhibitory drivers. So to me, it looked like a light switch you turn on and turn off. So Scott, can you help us understand, first of all, am I interpreting these models correctly? And how far along are these models? Are these proven? Or could there be more? Where are we in really discovering this pathophysiology?
Yeah, I think it's fair to say that these are two models that have been proposed. We don't have good evidence for one or the other. And these are, given the knowledge that we have today, these are two really good candidates for the underlying pathophysiology of this phenomena. I think there is an analogous process called autonomic dysreflexia, which we understand a little bit better. Autonomic dysreflexia is something that happens in patients with spinal cord injuries, where they get into a reflex loop that causes them to develop tachycardia and uncontrollable hypertension that can sometimes lead to cardiac arrhythmias. And we believe that this phenomena is caused by a loss of inhibitory signals coming from the brain to tamp this down. And so the theory that looks at the brain's inability to have the inhibitory things that keep the tone of the sympathetic nervous system, at a normal level, likely comes from a model that we understand a little bit better with autonomic dysreflexia. And then, we also put in here the traditional thinking that, the tone of the sympathetic nervous system and the tone of the parasympathetic nervous system sort of live in a balance. And, our hypothalamus and the thalamus and these structures in the very center of our brain, which are really hard to study because they live in such a delicate area of the brain, we think that those things live in balance with each other. And is this simply the fact that this gets out of balance and the brain lacks the ability to sort of bring the horse back into the barn? Right now, we don't know which model is correct. And I suspect that with increased research due to the increasing prevalence of this that people are seeing, I'm hopeful that we're going to understand more what's underlying this. And hopefully that will give us insight into how we can treat it a little bit better.
That was great. Thank you. Now, the paper then gets into trying to figure out where lesions are that cause PSH. They discuss patients with midbrain and pontine lesions are at increased risk of developing PSH, as are those lesions in the periventricular white matter, like Toshi said earlier, corpus callosum and deep gray matter. Also, the internal capsule, posterior limb of the internal capsule. It's unlikely that any of these lesions specifically drives the development of PSH, and the development of the syndrome is more likely to be associated with the overall burden of injury. And they feel that the findings support the suggestion that PSH is a complex disconnection syndrome with a learned allodynic, I don't even know how to pronounce the word, but allodynia-like hyperresponsiveness having a contributory role, as suggested by the excitatory inhibitory ratio model. So allodynia hyperresponsiveness in PSH develops as a consequence of impaired control by higher cortical centers, resulting in sympathetic storms. And now, Toshi, I guess my question from a neurologist perspective, can you look at neuroimaging from a patient with brain injury or hypoxic ischemic encephalopathy and say, I think that patient probably will have PSH? Are we there yet, or is it really something you need clinical data for?
So I'm only a trainee, so things will
Sure.
need to be taken with a grain of salt. But From my understanding, neuroprognostication is very complex. There are certainly instances such as a severe central pattern of hypoxic ischemic injury where part of the prognostication discussion can include not just things like tone changes, motor changes, cognitive changes, but the possibility of these autonomic storm episodes that we call PSH. But I think there's no way with most of neuroprognostication, there's no guarantee. I think the best we can do is when we see signs of deep gray nuclei involvement, brainstem involvement, severe cortical involvement, that those are times that it will be more likely that we might see PSH coming up.
Okay, that's great. Now, the next thing they talk about is therapeutic options and the three main goals when treating patients with PSH, according to this paper: avoid triggers that provoke the paroxysms, to mitigate the excessive sympathetic outflow, then to address the effects of PSH on other organ systems through supportive care. And the level of evidence supporting therapeutic options are low. At the time of this writing, there were no randomized controlled trials, just small case series. And it was also unclear whether these interventions affect the long-term outcomes of patients with severe brain injuries and PSH. That was unclear. And they then talk about the drugs that have been tried. Many drugs have been tried. No drug is universally or even predictably effective. In practice, most patients require treatment with multiple drugs and potentially complementary roles. Now, Scott, for you, the first thing is you agree with those three main goals when treating PSH: avoid triggers, mitigate sympathetic excessive outflow, and address the effects of PSH on the other organs of supportive therapy.
Absolutely. Yeah, that's the goal of therapy here. And, I'll just add to what you said and agree with it. That's where we were in 2017 when this paper was read. And that's where we are today. We're in a symptom mitigation mode here. And again, trying to help families identify things that trigger this, and then coming up with medications that can make the symptoms less prevalent, and when they happen, less severe. And then giving families options of medications that they can give when we do see spikes. And, I want to be very clear with families when we start to think about treating this, that we're unlikely to make these episodes go away. The goal of our therapy is to prevent them from happening, and when they do happen, have them be less severe so that we mitigate the risk to other organ systems in the body and, optimize the child's comfort, because these episodes certainly don't look very comfortable.
I agree with that. I've seen a few of them. Now, my favorite line from this paper is, and I even wrote my favorite line on my notes here: individual drugs and drug combinations are typically chosen on the basis of local custom rather than objective evidence. Now, and Tosha, I know you've done research in this, but Scott, we read your bio, and you've been in a few places. Have you noticed differences in regions from just your travels and working in different places?
Absolutely. And I think obviously, I'm old enough at this point that I've trained in different eras as well. When I was a resident, we would manage this typically with benzos, and we called this thalamic storming, which is a very unhelpful term. And so, I always was trained that the way you manage this was with benzodiazepines. Julie Hauer, who is sort of an icon in the care of children with severe neurologic injury, wrote a book called Caring for Children Who Have Severe Neurologic Impairment. The first edition of it was published back in 2013. And, she's made great inroads into helping clinicians think about how to approach this in a more stepwise and symptomatic approach. And pretty much everything I do to address this symptom comes from her. And so I want to give credit where credit is due. Dr. Julie Hauer is sort of leading the way in helping us think about the best ways to care for children with severe neurologic injury. And so yeah, there is a lot of well, this is what we've traditionally used, and this is what I'm going to start with, and this is where I'm going to go. Hopefully, people will think about the work that Dr. Hauer and the other people that have published these papers have come about with it, and try and approach this a little bit more systematically. Everything you said is absolutely true about the idea that many of the ideas for treating this comes from case series, and we'll probably get into that with the next article because as they talk about different treatments, they cite where they got these different treatments from, and it's a bunch of case series reports, right? And so because we're still in our infancy of our understanding of what this is and what causes it, we're even further behind in a systematic way to approach it and treat it.
Now, Toshi, this seems like a good place. Scott, thank you. That was wonderful. Scott, this seems like a good place, Toshi, for you to talk about some of the research you have done on this in terms of regionalization. Would you like to bring that up now?
Definitely, because as a resident here too, I've definitely anecdotally heard that the way that PSH is treated and what specialties manage PSH is very institutionally dependent. So me and my research mentors were able to conduct a national survey among 295 pediatric attendings throughout the nation, and even some from Canada, to kind of look at what specialties, quote, own PSH, as well as at all these different institutions, what medications are people using and finding success with. So we were able to get a total of 295 respondents with a pretty good split between palliative care, pediatric neurology, complex care, and PM&R, as well as some respondents from general pediatrics and critical care medicine, with a pretty broad scope throughout the United States. We found out from a specialty standpoint that it is very divided for both inpatient and outpatient. PM&R is the most frequently involved specialty. For outpatient, 37% of respondents said that PM&R is the primary manager of PSH, and for inpatient, 32%. However, there was a large amount of heterogeneity. So for outpatient, followed by PM&R, it was pediatric neurology at 27%, complex care, 13%, palliative care, 11%, general pediatric, 2%. And for inpatient, it was pediatric neurology at 26%, CCM at 16%, palliative care at 12%, and so forth. So I think what was interesting is, depending on what hospital you go, you could suddenly be responsible for managing PSH, even if you didn't have prior exposure to this entity. From a medication standpoint, there were some commonalities. The way we phrased the survey questions were, if a child right in front of you is having an event of PSH, what medication would you use to abort it? And for a patient who has had PSH episodes, what medication would you use to prevent future episodes, to kind of break it down between abortive medications and preventative medications? We found that for abortive medications, benzodiazepines and GABA A agonists such as clonidine are the most favorited medications. Benzodiazepines, 86% of respondents said that they would consider it, and alpha-2 agonist, 79% of respondents said that they would consider it, followed by medications such as opiates, beta blockers, non-opiate analgesics, which were around in the 40% range in respondents who said that they would consider it, and less commonly, gabapentin, baclofen, hydroxyzine, dantrolene, bromocriptine, which tend to be, even when used, more for refractory cases. For maintenance medications, the medications were a bit different. 90% of people still said that they would use clonidine, but only 51% said that they would consider benzodiazepines as long-term preventative medications. And instead, there is a large proportion that would consider gabapentin at 89% of respondents. And I think what was also interesting was, after we asked the participants, what medications would you consider, we then asked them to rank it in order of most common to least common prescribed medications. And we found that there is a big divide in what medications people grabbed first. So for abortive medicines, people, like I mentioned a little bit earlier, were split on the first line between Tylenol, ibuprofen, which are non-opiate analgesics, as well as benzodiazepines and clonidine. All three of the medication choices for those three were split about 28% each. And for those who said Tylenol ibuprofen, when they got to the second line, third line medications, they also too said benzodiazepines or clonidine oftentimes. In terms of preventative medications, the split was different, like I mentioned. It was more so gabapentin and clonidine, with a minority having propranolol as their first line. The number of people who opted for gabapentin as first line for preventative was 39%, followed by clonidine at 34%, followed by beta blockers at 18%. And again, in both abortive preventative medications, when it got to more refractory cases, some people then opted to go for the less commonly used medications such as baclofen, benzodiazepines, bromocriptine, opiates, dantrolene, and so forth. And I think one more interesting thing that we found was similar to how, depending on the institution that you work at, the specialty that manages PSH is different. We also found that depending on what specialty you come from, the choice of medication is also different. So we found that for abortive medications, alpha-2 agonists, opioids, and dopamine agonists, there was a significantly different practice pattern when comparing neurology, palliative care, complex care, and PM&R for abortive medications. And for maintenance medications, similarly, alpha-2 agonists, opioids, beta blockers, and dopamine agonists were significantly different in practice patterns between those four specialties. And I think that's an important part to bring up, because if we're seeing that the specialties that manage PSH is heterogeneous, and also depending on what specialty you have at your hospital, their practice pattern is different, that we don't yet have data on is there difference in efficacy between these medications. But I think it's a big point for future research.
Well, I appreciate that, Toshi. And that gets through the rest of the paper, because the rest of the paper that I had was talking about some of those medications. So gabapentin, used to treat neuropathic pain, has well-documented effects on presynaptic voltage-gated calcium channels in the dorsal horn of the spinal cord, clinically useful. They felt alpha-2 adrenergic drugs acted through central and peripheral suppression of adrenergic outflow. Clonidine reduces heart rate, blood pressure, and circulating catecholamines, but it appears to be less effective in controlling body temperature, but they found it helpful. They did talk about the third class, and propranolol was the most common of the non-selective beta blockers used. And then, of course, baclofen and dantrolene. Scott, anything about what Toshi say surprise you, or are you not surprised by it?
Yeah, I think Toshi's data beautifully confirmed the things that I had suspected, that there's a lot of regional variation in how we treat this, and that there is a lot of variation amongst specialists. And I see that even in our own hospital. I work really closely with our physical medicine and rehabilitation team, and they really like to use propranolol, and I tend to like clonidine and gabapentin. And I don't know which one of us is right. At the end of the day, as a palliative care physician, I care that the child is comfortable and that the family has the tools that they need to keep the child at home and out of the hospital, where I know that those kids do best. And so, I feel like there's multiple ways to get to a good place with these kids. And I think that's what I want to emphasize. We've talked a lot about lack of standardization, lack of understanding about what's causing this. But what I want to emphasize is that we can help kids with even severe PSH live good quality of life and have good symptom management with this. The vast majority of children that I treat with PSH, we can achieve good symptom management.
I think that's a very important point. I mean, it stresses the fact that we've been stressing the condition in terms of pathophysiology and what is known and unknown, because we're an educational podcast. But the key thing one of the things I take from this is I want somebody with experience in this taking care of a child who has it, because at this point, experience matters a ton. And definitely your group has that. The one thing I will say, I'll end this article. We still have a whole other article to do, and I'm very behind on my time. Additional therapies in PSH. They talk about physiotherapy, nutrition, because the increase in resting energy expenditure up to 3 times baseline have been reported during these paroxysms. Scott, in your experience, do you use those? Do you find it helpful to nutritional to really closely watch a nutritional input, or do you use physiotherapy? Does any of that help? This was published in Belgium, so they have different physiotherapy there. So it may not be something we do here in the USA.
Yeah, I agree that the number of pharmacologic and non-pharmacologic treatment modalities are really important in keeping kids comfortable in general and in keeping kids with PSH comfortable. The thing that I will say about feeding is, certainly during an episode of PSH, the caloric demand and the caloric intake needs are certainly changed. And if a child lives for prolonged periods of time in these episodes, then yes, I think you could reasonably say that they have increased caloric needs. And I just want to harp on this just for a second, because we tend to overfeed children with severe neurologic injury. And Julie Howard talks a lot about this, and I think she's really, really right about it, that a lot of these symptoms are triggered by GI distress, and a lot of that comes from overfeeding. These patients have very few caloric expenditures outside of these events, and hopefully we're controlling these events to a point that they're not having, they're not getting into a catabolic state because of it. One of the key things that Julie Howard does when a patient is struggling with this symptom or any other symptom or neuro pain or irritability is she cuts their feeds. Kids, when we cut their feeds, kids often do a lot better. And this is something that, I would love to address with the thought groups that oversee our pediatric nutritionists, is to really revise the way that we think about providing artificial hydration and nutrition to children with severe neurologic injury, because I think that when we have this wrong, it throws a lot of other things off, including PSH.
I did not know. It's a fascinating point.
Mm-hmm.
All right. Home stretch. Sorry, Toshi, go ahead.
And on a related note, I actually have a question to Scott, because I think from a neurologist lens, one of the ways that I've been more recently conceptualizing PSH is similar to migraines, where you can have a primary headache disorder or a secondary headache disorder. But like we talked about, PSH is a diagnosis of exclusion, where if you have an external factor causing it, then the goal is going to be to take care of that external factor. And I feel like one of the thoughts that I was thinking about was, at least at Children's Hospital of Pittsburgh, a lot of times I see, especially when we get an initial consultation of, could this patient be having PSH? We often do a head-to-toe physical exams, making sure that we don't have ear infection, tracheitis, abdominal tenderness, pressure ulcers, hair tourniquets, urinary retention. Is there any triggers, such as being feed related? Are there any infections or spasticity issues, medication changes? And when I've been more recently thinking about it, I wonder if a good framework to have would be, let's rule out the secondary causes that can cause discomfort for these children with SNI, which the discomfort can often present with sympathetic overdrive. And if those are fully excluded, then you can have a primary diagnosis of PSH. And of course, this is something that is only in my mind right now. There's no literature to support it, but I've been wondering this as a potential framework.
Well, I think by definition, PSH is a secondary disorder, right? Because it's secondary to some sort of neurologic injury, whether it's anoxic or traumatic or stroke related, hemorrhagic related. Within PSH, there are some kids who will have a PSH episode where we don't identify what's triggering it. but we certainly know all of the things that you just listed are triggers. And when children have bronchiolitis or an upper respiratory infection or some other issue, just like those things lower seizure threshold, and we see more seizures in kids with seizure disorders, and those things, we see more PSH. When the kid's body is under stress, we see more PSH. And so all of those things are triggers. And so when I come up with a treatment plan for a family, number one on that list is examine the child and determine if there is any easily reversible trigger. Does the child need to be changed? Is the child lying on something? Is there a hair tourniquet? Do they need to be repositioned? Are they late for a feed? Are they constipated? All of those things are potentially reversible triggers of PSH. And the first step in trying to address an episode of PSH is to try and identify if there's an easily reversible trigger.
Yeah, you said that. It struck me how many families of kids with PSH have said to me, if my child gets constipated, they will storm. That happens all the time. I hear that constantly.
Yeah.
And so the GI stooling is very closely watched by everybody.
Which gets back to Dr. Hauer's point that the GI system is really does play a role in this. And we know that the brain and the gut interact in ways that we're only just beginning to understand. And we see this, and Dr. Hauer's on the right track in helping us understand how GI distress or GI discomfort can really lead to a whole host of other symptoms in children with severe neurologic injury.
Now, we got to get this last paper. If you're listening at home, if there's one paper you're going to read, it's this last one that I'm going to have to rush through because I'm over on time. So it's called Paroxysmal Sympathetic Hyperactivity, Development of a Pediatric Clinical Practice Guideline. It was by Richard Carrozza, pardon me if I mispronounce your name, Deepankar Mohardi, and Michael Wolf et al., published in Hospital Pediatrics, Volume 13, Issue 12, December 2023, a few months ago. So first, their definition, which is great, a syndrome associated with antecedent brain injury characterized by episodes of sympathetic overdrive, primarily manifested as episodic vital sign instability, tachycardia, tachypnea, hyperthermia, hypertension, with increased neuromuscular tone and other clinical manifestations such as diaphoresis or mydriasis. Now, that was one of the best definitions I have read. I love that definition. It's really clear on what we're talking about, this PSH or autonomic storming, whatever you're calling it. They went through old names, which we've talked about. They linked back to the 2014 paper we talked about. They talk again about that the way to think about PSH, it's believed to be a disruption of excitatory inhibitory pathways, which typically allow for modulation of response to stimuli. It cannot be localized to one region of the brain, but rather appears to be a broad disconnection syndrome and diffuse injury axiomatic to its pathogenesis. It predominantly occurs in the acute phase after neurologic injury, frequently within the first week, with decreases of rates of onset and severity as time elapses. Patients exhibit on average 5.8 paroxysms per day during the initial stage, with an average duration of half an hour, ranging from several minutes to 2 hours. And normally the severity and frequency of the paroxysms improve over several weeks, but often tachycardia, diaphoresis, and posturing persist beyond this time. And however, some patients will continue to experience chronic symptoms on the orders of months to years, which is the kids we see. In adults, it primarily occur after TBI, but in children, PSH may be more common after a anoxic brain injury rather than TBI, and even more frequent after meningoencephalitis. And they talk about the management of it, how it must be personalized. This was initially a QI study done at a hospital trying to structure this in a way that made sense. It was very well done. They want to personalize the management to patient-specific pathology, and historically there's been a lack of formal guidance regarding this. In the experimental and clinical setting, the majority of paroxysms are induced by external stimuli. Allodynia is pathognomonic to PSH, and like we've been talking about, avoiding causes. So urinary retention, fecal retention, pain and noxious stimuli. And various methods have been used to curb sympathetic response. Like we talked about propranolol, beta adrenergic antagonist, alpha adrenergic agonist, clonidine, dextrometamidine. Opiates and gabapentinoids have been used to modulate allodynia and reduce the reaction to perceived nociception. GABA receptor antagonists and benzos, baclofen, have been used for tone management and sympathetic modulation. They use bromocriptine, propofol, dantrolene in varying degrees of success. Antipsychotics are no longer recommended. And again, they talk about here, besides propranolol, most of the evidence is small case studies. Propranolol is the only one where there's any type of larger data. And I think, Scott, you brought that up. And they talked about that PSH-focused pharmacotherapy has not been determined that if will it improve long-term outcome yet. That's still undetermined. It improves short-term outcome and patient comfort, like Scott's been saying. And then, Scott, my question to you from this, they talk about the development of PSH is widely considered to be an independent risk factor for graver neurologic outcomes, even for those with a brain injury. So in your experience, do you see PSH progress over a child's lifetime who had an anoxic brain injury? Does it get worse? Have you seen it get better?
Yes to all of that.
Okay.
So, I think the patients who we traditionally think of who have their symptoms abate over time are children that have suffered a traumatic brain injury. There are good papers and good data that show, especially as Toshi mentioned, Erica Fink's group that studied traumatic brain injuries really in depth, that we do see this symptom tend to get better over time. And so in that group, and the patients that I tend to see are kids that have suffered an anoxic brain injury. And I tend to see these be static or get worse over time. And I think that in a child who has suffered such a severe brain injury at such an early time in brain development, as the rest of the body starts to develop and the brain's just not developing, that leads to a lot of dysregulation between what's happening, above the neck and below the neck. And so I do tend to see this sometimes get worse in kids like that, especially, in lots of kids with severe neurologic injury, they develop intestinal failure over time, along with chronic respiratory failure. And as symptoms from those things get worse, we tend to see worse PSH. But when I counsel parents about this, and when I'm seeing it, especially in the infancy period, I'm very honest with them about the uncertainty of the situation. And I tell them, this is something that we may deal with for the rest of your child's life. It may get worse or it may get better. And right now, I don't have any great way of predicting which direction your child's going to go, because I have seen kids with very severe PSH in the infancy period who get to school age and really have very little problems with it. I've seen kids completely come off of medications, and I don't really have a great way of predicting who that will be and who it won't be, other than noting that in children that I see with a traumatic brain injury, I do tend to see them get better a little bit more frequently than kids that have suffered an anoxic brain injury at birth.
That's helpful. Now, finishing the study, they went through their methodology, which we're going to have to ignore to make these guidelines. They created they modified the paroxysmal sympathetic hyperactivity assessment measure from the first paper. They split kids up into 3 groups, 1 to 4 years old, 5 to 15 years old, and over 16 years old. The score they would calculate, because they're trying to make this structured for their entire hospital. They calculated the CFS, or the clinical feature scale, plus the DLT, or the diagnostic likelihood tool, from earlier on. So a score of less than 8, unlikely to be PSH. A score of 8 to 16, possible PSH. More than 17, or equal to or more than 17, probable PSH. So they give them a score if this is PSH or not. And then if they think that the score is greater than or equal to 8, The nursing staff record the CSF subtotal once per 12-hour shift, as well as paroxysms, and they put it in the flow sheet in the EMR to grade it over time. They first do non-pharmacologic measures, reducing stimulation levels in the room, dimming the lights, turning the volume down on everything, looking for skin breakdown, repositioning the patient, checking medical devices, ruling out UTI, constipation, etc., which we've talked about. And then they characterize the treatment modalities by their clinical target, increasing tone and posturing, vital sign abnormalities, and pain. And then separate drugs were used for each of those things. So tone issues, the baclofen was first, benzos were second line, pain control, opiates, gabapentin, vital sign abnormalities, they use alpha adrenergic agonist, propranolol, bromocriptine. And they discussed how both the CFS and DLT have subjective components, and these have been widespread use in the treatment of adults with PSH since it started. And then the use of this validated reproducible scales with subjective components is common in pediatric critical care, so they use it. And then they talked about how it worked, and they instituted it. I thought it was an interesting idea to really kind of structure this in a way where everyone was on the same page. It's kind of where hospital medicine is going with clinical effectiveness guidelines. They talked about the drugs, benzos, gabapentin, and propranolol. What I liked about this paper, they talked about refractory patients who failed 2 medicines and continue to exhibit paroxysm should prompt intensive care consultation. They created a system that made a lot of sense for their hospital and tried it out, and I'm sure there'll be follow-up papers on it. But their intro really did a nice job discussing PSH if you're new to it, defining it, talking about the drugs, the pathophysiology. I guess, Scott, my question to you, do you see this as where hospital systems either will go or should go as where the bigger ones are starting to see more kids with PSH, kind of a structured definition, a structured scoring scale, a structured plan, or what do you think? What's your opinion on this one?
Yeah, that's what this symptom has needed for a long time, for everyone to call it the same name,
Well, that's true.
for everyone to think about the reasons why it's occurring, and for everyone to think about the best way to handle it in a way that is guided by the child that you are trying to treat. I mean, these authors, like, props out to them. This is a great paper. And, I love figure 3 in this paper that gives us sort of a schematic and a way to think about how we manage this symptom. And, they do a lot of the things that I try to do. So, if I have a child who has a lot of dystonia, dystonia is not comfortable. It is not comfortable to be in, flexion in all of your extremities 24 hours a day. Dr. Tarchichi, you and I, we follow a patient on our services who has pretty significant dystonia that leads to really significant PSH. And when I first met him, because we were called to help manage his PSH, I said, this kid needs more baclofen. If we can adjust his baclofen, I think we can make him a lot more comfortable. And I think what's triggering his PSH is his tone and the discomfort that comes along with that. So short term, I was managing him with pain medications to try and get him through that, while I asked my physical medicine and rehabilitation colleagues to adjust his baclofen. We adjusted his baclofen and things got a lot better. Whereas for kids that are very irritable and present with a lot of crying that then tends to escalate to PSH, I'm much more likely to choose gabapentin to try and treat that symptom. And if it's a kid where I don't really have a whole lot of clear triggers, and this is the majority of kids, that is when I'm going to reach for clonidine as my first drug. And I point out, for reasons probably rooted in the amount of data that's available, in their paper, they're saying their first line medication for this subgroup of patients is propranolol. And I don't have any data to say they're right or wrong about that. I just, I'm from the Dr. Hauer school, and I'm reaching for clonidine first for the majority of my patients. And why do I reach for clonidine first? One, because I think like propranolol, it will deal with the vital sign abnormalities. It will make the heart rate better and it will make the blood pressure better. But I'm not fully convinced that propranolol makes some of the discomfort or dystonic reaction that comes from it, or the flushing or the sweating. I don't think it really makes those things better the way that clonidine does. And so that's why I tend to reach for clonidine. If a patient's simply tachycardic, sure, I'm game for propranolol. Otherwise, if they're having other physiologic symptoms that go along with their vital sign changes, I'm going to reach for clonidine. And the other reason I love clonidine is you can put clonidine in a patch and it becomes a really great baseline medication the kid gets habituated to and doesn't have a whole lot of sedation from over time. It's far superior to benzodiazepines in that regard because we're you got a kid with a severe neurologic injury and we're going to put them on chronic benzodiazepines. That's not good for neurodevelopment.
Right.
And so, clonidine tends to be my go-to drug. And I usually start at 5 to 10 micrograms per kilogram per day. And I titrate to effect. Dr. Hauer says, she can go up to 20 or 25 micrograms per kilogram per day, depending on the tolerance of it. I tend to find that these kids tolerate this very well, and I don't deal with a lot of hypotension or other issues. That tends to be my go-to drug. But I love the way that they've brought this about. I love the way that they target their therapy based on the primary symptoms that the kid is presenting with. And I think that, if you think a kid has increased tone or posturing, and dystonia is a big part of this kid's life, and that could be triggering PSH, then let's target that first and see if we can just solve this with one drug or a series of drugs as opposed to a ton of polypharmacy. And then there are some kids who just need polypharmacy and they need multiple modalities. And I have patients that are on baclofen, clonidine, gabapentin, ERN, benzos. And that's what we need to control their PSH. And over time, if we are not using PRN medications, then that gives me an opportunity to say maybe this patient's PSH is improving for reasons I don't understand. And I can start to back off on the baseline medications that I've got them on. But my favorite PRN medications are using PRN clonidine, which I typically use at 10 to 20% of their total daily dose. I'll give them that every 6 hours is needed for that. And then I'll give them a benzodiazepine like lorazepam in case of emergency break glass drug. And I usually rely on the parent to tell me which one they think aborts the PSH better to be their first PRN and then have that be their second PRN. And then I think the other thing when we talk about management here that they nicely point out here is, if we make two different, if I've got a parent who's given one PRN and that didn't work and a second PRN and that didn't work, I tell that family to call our on-call provider because I want to troubleshoot with that family. Is there potential triggers or something that we could change? You got to make sure that these families have the ability to call someone day or night if their kid's not responding to the treatment plan we put out there. And when I put a really clear treatment plan out there, it's rare that I get a call in the middle of the night. If a parent is calling me in the middle of the night, something's up. And so we've got to give, if we want to focus on keeping these kids in community, we've got to give access to these families because these episodes are really scary to watch. And when you look at the kid, gosh, they look really uncomfortable. And I would never want my child left like that for a long period of time. So we've got to be available to them to help them through these symptoms. Otherwise, these kids are going to live in the hospital. And we know that's not good for them or anyone. And so we got to make sure that there's an availability for parents to reach out to if they're running into trouble.
I think that is a fantastic summary of how to approach this, Scott. Thank you very much. That was great. And availability is crucial. We often don't think about that as hospitalists, but you do, and that makes a lot of sense.
That was friends are.
No friends are. That was everything I wanted to cover. Toshi, I'll kick it out to you first. And Scott, is there anything we didn't talk about that you felt we should have, or we should have done better on?
No, I think we covered a lot of great things. I think the especially as someone who's a trainee who's looking to become a junior attending, I think it just shows a lot of future opportunities for research, and there's so many areas that there still needs to be work done on.
Scott, you're up. Thank you.
I really want to thank you for highlighting this. This is a symptom we're seeing more and more of as the population of children with medical complexity grows. We're going to see more of this, and more hospitalists and more pediatricians out in the community are going to see this symptom. And the better they are equipped to handle this, and the better they are to know who to call when they need help, it is going to help kids in general. And so I just really appreciate the time you've dedicated to the topic of taking care of children with severe neurologic injury.
Listen, it's my pleasure. And I thank you guys. Speaking of time, I told you an hour, we're over an hour. So thank you for your time. Thank you both for coming on. I really enjoyed this, guys. Thank you so much.
Thank you for having me.
Yeah, thank you for having me as well.
Time for our acknowledgments. I want to thank our special guest again. I really do appreciate your time. I want to, as always, thank the UPMC Children's Hospital of Pittsburgh, and specifically the Paul C. Gaffney Division of Pediatric Hospital Medicine for continuing to support the podcast. I want to take the time to remind our listeners that there is CME associated with most of our podcast episodes, courtesy of the University of Pittsburgh. So thank you, University of Pittsburgh. Please just click on the link at the bottom of the podcast. Takes you to a web page. Create a free username and password. Answer some questions that I write that are not hard. And that's it. You get AMA Category 1 CME credit. I want to, as always, thank and acknowledge Dr. Megan Keene Tarchichi, who helps me with everything. But I really want to thank you all who are listening. Thank you for letting me come into your earbuds or your car, wherever it is you are. I really appreciate the fact that you do that. If there's anything you want to hear or think we can cover better, any comments, suggestions, compliments, whatever you want to do, again, as always, please feel free to email me at tony.tarchichi, @chp.edu. Thank you again, everybody. I hope you have a great day. We'll see you next time.
Thank you for listening.